Hello and welcome wherever you are in the world. This is a great pleasure to speak to you today in this live webcast, charting new paths in the treatment of hormone-positive, HER2-negative metastatic breast cancer, trying to seek clarity and consensus through evidence-aligned clinical cases. Let me just advance the slides. I'm joined today by my colleagues in terms of the faculty. I'm Professor Stephen Johnston, Head of Breast Medical Oncology at the Royal Marsden Hospital in London. I'm joined by my colleagues Valentina Guarneri, who is Professor of Medical Oncology at the University of Padua in Italy, and my colleague Professor Patrick Neven, who is from the Department of Gynecological Oncology in the Breast Centre at Leuven in Belgium. Welcome to you all. So we're grateful to PeerView for providing this session, for Lily for the educational grant for this symposium. Please feel free to take part in polling during the program because we want to hear from you. There is a chat function that you will be able to submit your questions as we go along. I'll look at those and then bring those questions in when we have a discussion around the cases, and we'll have a time right at the end for any direct questions that haven't been covered. You will be able to create a slide collection from the Catalyst tool, so you can access this through the QR code. In terms of other activities, in terms of slides and practice aids, you can access these also through the website. So the goals today are to look at why it's important to recognize the varied clinical spectrum and different subpopulations of patients in hormone-positive metastatic disease. We'll look at how the new targeted therapies that are coming through can overcome endocrine resistance and the limitations of some of the standard therapies. And we'll focus in particular on the role of oral SERDs and other endocrine therapies as monotherapies, but also how combinations are poised to impact standard of care in hormone-positive metastatic disease. And then we'll select and sequence the current treatments through the cases that we will be discussing. So I'm going to pass over now to Professor Guarneri to take us through some initial slides looking at refining treatment options in the first-line setting. Valentina.
So thank you, Stephen, for the introduction. It's a pleasure to be here and just to review with you the what are the options in the first-line setting. In particular, of course, we all agree that the CDK4/6 inhibitors in combination with hormonal therapy is the mainstay of therapy, but of course we will see how this scenario can probably be modified. So this is just a polling question, in particular just to hear from you in this context of an evolving evidence and increasing the number of treatment options. So what are the main challenges when facing patients with hormone receptor positive HER2 negative metastatic breast cancer? So the identify subgroup of patients with different probability to respond from treatment in this subgroup, so to refine treatment accordingly, the role of biomarkers, the optimal selection in second-line therapy that of course is influenced by the decision we made in first-line therapy, and other of course important aspects are quality of life, side effect of our therapy, and of course what is my perspective is that we have to deal with all these aspects when deciding treatment for our patients. And so we have seen, as mentioned, the results of very important trials, really changing our approach to the treatment of hormone receptor positive HER2 negative metastatic breast cancer. Here you can see just a summary of the main results of the trials evaluating CDK4/6 inhibitors in combination with hormonal therapy in both the setting of endocrine sensitive disease and endocrine resistant disease. So we have very important data on the combination with AIs and palbociclib, ribociclib, and abemaciclib, and also very important data in combination with the combination of fulvestrant plus palbo, ribo, and abema. And as you can see, we have very consistent results in terms of the improvement of the combination in progression-free survival, data that are very consistent across the different trials. And of course, what is very important is when looking at the long-term data, we really see that there is a significant proportion of patients who are still free from progression. And probably one of the next challenges will be to identify those patients that really derive the most benefit from this approach in first-line therapy. And here you see the results of the PFS from the MONALEESA 2 and of the Monarch 3 data. Another, of course, very important endpoint when dealing with patients with metastatic breast cancer is the overall survival. And here we can see that we have trials that formally reach the OS benefit in endocrine sensitive as well as in endocrine resistant disease. And this is just not intended to cross-compare trials, but here are the results of the Monarch 3 and of the MONALEESA 2 trial, evaluating abema and ribo respectively in combination with AIs. And you can see that MONALEESA 2 formally demonstrated a significant overall survival improvement. So very important data. We have a median OS of 64 months. And we're looking at the data from the Monarch 3. Of course, we have to acknowledge that this is a different study in terms of the statistics because we have the randomization 2-to-1. And this trial at the final analysis not result in a really statistically significant OS benefit in terms of the p-value, but you can see that in patients treated with abema in combination with AI, we have a median OS of 67 months, which is one of the longest observed in this setting. So in my view, very solid data, very important data for our patients. And the important part from my side is that we have options. We know that palbo, ribo, and abema have a slightly different safety profile, which is of course dependent on the fact that we have different activity on the spectrum of the kinases. In particular, palbo is more associated with neutropenia. With ribo, we have the issue of QT prolongation, and abema is associated with an increase as compared to the other of the GI side effects. But in the end, I think all of us are very familiar with the use of these agents. We are very also now skilled in the application of dose interruption or dose reduction to manage side effects. So I think that we don't have any longer issue with these agents when used in the context of our breast cancer patients. And these are also data showing the efficacy of this strategy in the context of patients presenting with endocrine resistant disease. As you can see, we have the results of Monarch 2 and MONALEESA 3, both significant from a statistical standpoint, but also from a clinical standpoint in terms of the prolongation of PFS and also of the overall survival. So these are the standard treatment approach for patients with presenting with endocrine resistant disease. And as discussed, probably this scenario is evolving because we have seen the results of the NAVO 120 trial evaluating the role of inavolisib in combination with fulvestrant and palbociclib versus fulvestrant palbociclib placebo in patients with PIK3CA mutation and endocrine resistant disease. Here you can see the main inclusion criteria. So PIK3CA mutation and progressing during or within 12 months of adjuvant endocrine therapy completion, no prior therapy for advanced disease. So and we have, regarding the prior exposure to treatment, half of the patients that were exposed to prior tamoxifen. So maybe we can discuss a little bit on these this combination is not yet approved, for instance, in Italy. So for the moment, we have no access of this strategy, but you can see very important results in terms of the significant prolongation of PFS, favoring the combination with inavolisib, and also of overall survival. Of course, when targeting the PIK3CA pathway, we know that we have to deal with this specific spectrum of side effects, including hyperglycemia, including stomatitis, diarrhea, and some cases of were described with the inavo of ocular toxic effect. So of course, again, we have very important data in terms of the efficacy of this strategy, and we have to be ready also to manage these kind of side effects. And so just to conclude this first brief overview of the data we have in first line, of course, it is the factors that we consider to personalize therapy in first line therapy relies on, of course, on the clinical evidence that we have, the differentiation in endocrine sensitive versus endocrine resistant disease, of course, a lot of data regarding patients' age, performance status, comorbidities, tumor burden, the biological characteristic of the disease, of course, the drug adverse events profile, in particular, taking into consideration the potential also drug-drug interaction, in particular in patients with the comorbidities requiring polypharmacies. Of course, the patient needs and preference. I have to say that working in Italy, the financial consideration are always an issue when selecting treatment, and probably on the basis of the results of the INAVO, we have to start to test PIK3CA probably in at least in patients presenting with endocrine resistant disease to decide for the first line therapy. And I have concluded my part, so I hand again to Professor Johnston.
Thank you very much, Valentina. And that's a really helpful overview of the frontline trials. A couple of questions have already come in relation to that, definitions of endocrine resistance, sensitivity, also the question of whether we're really curing some frontline patients. So hold those thoughts. We'll come back to that aspects in discussion, and please keep your questions coming through. So I'd like to now move the slides forward and introduce my colleague, Professor Patrick Neven, who's going to discuss overcoming limitations of standard endocrine therapies and introduce the concept of oral SERDs, monotherapy, combinations, other novel approaches. Patrick, over to you, and I'm happy to manage the slides as you're on a phone. So let me know when you're ready.
Yes, you can move on to the next one. Hello, everybody. Good evening. It's my pleasure, and thank you so much for having me. To guide the discussion, we have a couple of questions for you. Which of these options for patients who have been pre-treated with endocrine treatment and the CDK4/6 inhibitor are of concern? Do you still believe that fulvestrant can play a role, plus or minus the CDK4/6 inhibitor, in patients with an ESR1 wild-type status? Do you think that oral SERDs single agent are appropriate in patients with the ESR1 mutated receptor? Do you think that combinations are the best option in second line anyhow? Or are you not yet sure what is the best way, what is the best sequence to integrate older options, oral endocrine treatment, single agent, or novel combinations? So we will come back to these questions, and this will guide the discussion. Next slide. So we have for a long time have had a lot of anti-hormone treatments to interfere with the estrogen receptor interaction. This is a transcription factor that is ligand and non-ligand independent, and its dependency can disappear under the pressure of treatment. As you can see in this cartoon, under the pressure of anti-hormone treatment, you can see the appearance of the ESR1 mutation. We know that we need new drugs. We have good drugs, but for example, we have the selective estrogen receptor degrader fulvestrant, which has a poor PK, poor oral bioavailability. This necessitates intramuscular injection. So there we have limitations regarding the dose and dose-dependent efficacy. So next slide. To overcome these molecular alterations and resistant pathways, we will now focus mainly on the mutated estrogen receptor. There are two pathways that this can appear. The most likely is that this is de novo acquired. It's very unlikely to see this in the initial biopsy, so this appears under the pressure of anti-hormone treatment, and it appears in the patients where it's picked up today in 10 to 50% of the cases. So how can we restore endocrine sensitivity if the estrogen receptor is mutated? Next slide. When we deal with such patients who are endocrine resistant, we have to take other resistant mechanisms into account. We know that the combination endocrine treatment with CDK4/6 inhibition doesn't always mean that the patient has become resistant to the CDK4/6 inhibitor. With the emergence of the ESR1 receptor, we know that this can be blocked, and maybe also we can continue with the CDK4/6 inhibitor. Some pathways that we also know and can interfere are the PI3K, AKT, mTOR pathway. There, if we block this pathway, we know that the estrogen dependency increases. So we have always to block also the estrogen receptor with anti-hormone treatment if we give PI3K, AKT, mTOR inhibitors. Next slide. So to tackle this endocrine resistance, to restore endocrine sensitivity, for a long time we have had fulvestrant, but with the difficulties of reaching high enough doses if the estrogen receptor is mutated, we need these new generation oral SERDs. Tamoxifen, raloxifene, basedoxifene, fulvestrant, all of these anti-hormone treatment possibilities are still available. But once the receptor is mutated, we have now in green elacestrant and imlunestrant that are FDA approved, elacestrant also EMA approved. You can see that other compounds in orange are not longer further developed by the companies because they have led to disappointing results. And in blue, you can see that several trials are still ongoing. They all have their particular mechanism to interfere with the estrogen receptor as a transcription factor, and they are called estrogen receptor degraders. But we have different mechanisms like PROTAC, like vepdegestrant, also being active. And also for vepdegestrant, we now have clinical data as were published from the VERITAC-2 trial in the New England Journal of Medicine last May. Next slide. To focus on single agent SERD in patients who have become endocrine resistant following exposure to endocrine treatment and CDK4/6 inhibition, we refer to the EMERALD study. And in the EMERALD study, you can see that patients do benefit if they had a very long-lasting control on the prior line of endocrine treatment. So in second line, if you can select patients who had more than 12 months of disease control, they have the ESR1 mutation. There you can see that you can, from 1.9 months, reach 8.5 months for median PFS in this very selective group of patients. Next slide. Now moving on to the AMBER-3 study. Here we have also data with a same population of ESR1 mutated patients, although not all of these patients were pretreated with CDK4/6 inhibition. We can see that if imlunestrant, the SERD that was used in AMBER-3, was compared with the standard of care in these cases, mainly fulvestrant, there we can see an improvement of the median PFS of 3.8 months to 5.5 months, which is also clinically meaningful. It has to be said that this oral SERD, as with elacestrant, is not better than standard of care in patients with the wild-type estrogen receptor. Next slide. Here we have data from the VERITAC using vepdegestrant, as mentioned, published in the New England Journal of Medicine. And also here we see that as single agent, this is a PROTAC, compared with just fulvestrant in the control arm, increases your median PFS in a clinically meaningful way but only in the population with an ESR1 mutated receptor. In the wild-type patients and in the intent to treat population, this was not the case, and there was no difference in median PFS compared with standard of care fulvestrant. So this is really a ESR1 mutated-driven efficacy of these 3 oral SERDs. Next slide. So if you then look into this recent publication by the Lancet, EU Biomed, there they have compared a lot of trials using drugs, also SERDs, single agent or in combination. And here they considered which of the one has the best hazard ratio. You never can compare these trials in between, but looking into the hazard ratios, you can see that elacestrant, vepdegestrant, and imlunestrant as single agent were very efficacious to improve your median PFS, in particular that group of patients with an ESR1 mutated status. Next slide. Here we had the occasion to publish the different side effects of the SERDs that have been tested in clinical trials in Nature Review Clinical Oncology. And you can see that these side effects are quite manageable, are not very frequently present, and are not very toxic. Mainly they have low-grade GI toxicity. Some SERDs have particular toxicity, like camizestrant can lead to bradycardia and to photopsia. Next slide. So what about the combination instead of single agent oral SERDs? We know that if we look into all these different trials, you have 40 to 60% of patients showing an early progression. And if you have a response, this response is not long lasting. So we are looking for combinations of oral SERDs with a lot of different agents. Next slide. So these different agents, they can be CDK4/6 inhibition, but they can also targeting other pathways that might be activated when these patients show resistance to endocrine treatment. Here you can see the different pathways, the different drugs to interfere with these pathways, and most of these have been tried or are still going in combination with SERDs in second or in third line to restore endocrine sensitivity. Next slide. One of these experiences is from EMBER-3, where this was being tested in patients comparing imlunestrant, single agent SERD with the combination imlunestrant plus abemaciclib. 2/3 of these patients were pretreated with CDK4/6 inhibition. And if you look to these patients who were pretreated with CDK4/6 inhibition, then you can see a clinically meaningful improvement in the median PFS from 5.5 months to almost 10 months. So this is clinically meaningful, statistically significant, and this combination is clearly better than the single agent and was independent of the presence of the mutated estrogen receptor. Next slide. A recent presented disclosure was from Evera. Also here, they are including patients who were endocrine resistant. These patients could have 2 lines of prior treatment with an endocrine treatment, and they were enriched with the ESR1 mutation. So 55% of these patients included in Evera showed the presence of the ESR1 mutation. And what they did do is a revival of everolimus. So patients were selected. They were randomized 1-to-1, standard of care plus everolimus, versus giredestrant, oral SERD with everolimus. And here you can see in the patients who had on the left ESR1 mutation, a clinically meaningful doubling of the median PFS. On the right, you can also see for the ITT population that this was an improvement. But if you realize that over 50% of the patients had an ESR1 mutation, then it's not likely to see this improvement in the ITT. But if you focus only on the patients who had a wild-type estrogen receptor, there was no difference with the standard of care. And this was in Evera, most likely exemestane, with only 20% of the patients combined fulvestrant with everolimus. Next slide. So here you can see, and this is one of my last slides, on the Victoria 1 that was also presented during the last ESMO. And here the authors have used similar patients, endocrine resistant, prior treated with CDK4/6 inhibition. These patients were presented only for the subgroup of patients with the PI3K wild type status. So this trial also included patients with a activated AKT PI3K pathway, but this presentation was only on the wild type subgroup. So when they compare fulvestrant, they only reached 2 months, and that's what we see with these patients who were heavily pretreated. 2 months, but that was improved with the doublet using fulvestrant plus gedatolisib, and with the triplet, fulvestrant plus gedatolisib plus palbociclib, with a clinically meaningful improvement in median PFS. It has to be said that this drug is given intravenously. It's given 3 weeks out of 4, and also has particular side effects that look very much to what we see with mTOR inhibitors, like mucositis and not very high levels of hyperglycemia. Next slide. So to end here, you see in patients who have an ESR1 wild type status from all these different trials, that if you select your patients, that there might still be a role for single agent fulvestrant, and otherwise we will go for combinations to improve the median PFS. Next slide. This then is the entire picture, also including the 2 last disclosures from ESMO, Evera, and Victoria 1, where you can now clearly see that the median PFS can be improved above 6 months by combining these agents in patients who have been pretreated with a CDK4/6 and prior endocrine treatment. Next slide. So, Stephen, I now leave the word to you to continue the discussion. Thank you.
Thank you very much indeed. I think we've generated quite a few discussions and questions already in the chat, which I'm really grateful for. We may just take a couple of questions now, Patrick, related to that before we go into our cases. Do you think generally what you've just shown us about combinations, one of the questions that's come through is, do we think they're broadly better regardless of any alterations, and that oral SERDs really should be monotherapies only if in ESR1? I think we'll touch on this in our cases, but do you want to respond to that in the data you've just shown about monotherapies versus combinations, and where you think we're going to be going with this?
Yes, like Valentina said, we have to take a lot of different issues into account: quality of life, disease burden, duration of prior exposure to endocrine treatment with CDK4/6 inhibition. So we really have to make selections. Of course, then we have the biomarker if ESR1 is mutated, and this happens in 30 to 50% of these patients. And if we do proper selection, I think that's the limited group of patients where we see a place for single agent oral SERD. As you mentioned already, the combination is the one that we will see most likely in the clinic. Unfortunately, also in Belgium, we don't have these combinations available. We do have in first line CDK4/6 inhibitors, and it also depends on which type of CDK4/6 inhibitor the patients were prior exposed. If that was palbociclib, we have a better chance that continuing the CDK4/6 inhibitor, and this is independent of the receptor status, might lead to this 10 months of median PFS. Thank you.
Thank you. And before we get into our case, Valentina, one of the very early questions came on as to whether we think our current definitions of endocrine resistance that we've developed through the ABC group that met in Lisbon last week over the years, whether they're fit for purpose, because that was very much about endocrine monotherapy. We're talking now about combinations. Do we think we need to rethink our definitions of endocrine resistance, or do you think, broadly speaking, they're still valid for clinical decision making?
I think this is a very important issue, and I have to say that we try, at least at the national level, to reconsider the different criteria for endocrine sensitivity and resistance, in particular according to the exposure to CDK4/6 inhibitors, which now are also used in the adjuvant setting. So probably identify different patient population. I think that here, and I alluded to this when discussing about the INAVO trial, maybe in my view, what is critical is that we consider endocrine resistant the patients who, in terms of relapsing from adjuvant therapy, all the patients that relapse within 12 months from the end of any adjuvant endocrine therapy. But in my view, in particular, patients exposed to tamoxifen maybe in particular, if the disease relapse is after the completion of the 5 years, even if within 12 months, probably can benefit again from AIs. And by jumping on fulvestrant in this patient population, maybe we reduce the number of lines in the further progression of the disease. So I think that probably in my practice, I use a very pragmatic approach. The patient can still be sensitive to AI just to decide to inform on first-line therapy, or if, because of course, if a patient is relapsing within the first 2 years of receiving adjuvant AI, I think it's a different patient than as compared to a patient that relapses after 5 years of tamoxifen. So, but of course, we need to have guidelines to harmonize the criteria in the inclusion criteria in the trials. So I think we still have to stay on that. Of course, the differentiation in primary and secondary resistance, but again, pragmatic approach. What will be the best hormonal backbone to be combined with CDK4/6 inhibitors?
No, I agree totally. And I think broadly speaking, those have been incredibly helpful guidelines we've had for the last 8 or 10 years. It's all about prior exposure, duration of benefit from that therapy, and time off treatment. I guess two things are changing now is one, the integration of biological information from liquid biopsies on PIK3CA, ESR1, and we're going to go into that in the cases because that further refines your options in a resistant setting. Plus also, we're going to have CDK inhibitors up front in the adjuvant setting. So we're now potentially talking about resistance to both endocrine and CDK inhibitors. But, and again, Patrick alluded to that in that nice Venn diagram that the mechanisms can be different. So it's got more complex, but I think the principles of those definitions still last. So what we're going to do now is move on and look at some specific cases to tease out some of these themes that we've brought up. Still keep coming in with your questions and I'll try and touch on them. I've got a list of the ones you've already sent through. So let's meet a patient. She's called Amina. She's 65. She's postmenopausal. And she presents with newly diagnosed breast cancer that is metastatic. So this is de novo metastatic. She has a breast mass. And on workup by CT scan, she has liver and bone metastases, including a number of sites in her bone. The liver disease is relatively asymptomatic. It's small volume. Her liver function is normal. And biopsies of both the breast mass and the liver show ER positive 80%, negative for PR, negative for HER2. So consistent with de novo metastatic breast cancer. So she's well, she's asymptomatic because this was a breast mass that she found, but she's asymptomatic from the bone and liver disease, which although present is small volume. She does have some comorbidities, some ventricular tachycardia that's being treated. She has a QTc pro baseline of 480. So I'm going to give you some treatment options that you might consider in your clinic of treating this postmenopausal patient. First line therapy, de novo metastatic, untreated, ER positive. AI plus ribociclib, AI plus abemaciclib, AI plus palbociclib. And remember, Valentina showed you the data for all three of those drugs that are approved combinations. Do you think she requires chemotherapy purely because there is visceral liver disease, or are you a little unsure on the best option to go forward? So please place your votes in the poll. which will come through for a comparison later. So I'm going to pass to my colleagues in the faculty, and Patrick, ask you in the first instance what you think your option would be in this situation, based on the history of a 65-year-old with asymptomatic liver and breast mets in a first-line setting. What do you think of those options you would use?
I think I would rather go for the options that I do believe are maybe a little bit better than other options, and I certainly would not go for chemotherapy. I think I will explain this patient that I'm pretty sure that I don't have any doubt, and then I would take into account her baseline ECG characteristics with already a prolonged QTC, 480 milliseconds, her comorbidities. And I would here choose, together with my onco-coach, I think for AI and abemaciclib. If she was a little bit older, then I might still get a palbociclib chance. But if she is fit enough and she has a normal liver function, I would rather go for abemaciclib. Although I think palbociclib is also a very good option.
Sure. So I think, yes, Valentina, you showed the data, and obviously with Monarch 3, which was the first line data, very prolonged progression-free survival, and a group of patients that, 7 or 8 years out remain in remission. One of the questions that came through earlier on is, do you think if you achieve that sort of remission years out with no evidence of disease, we don't know about this individual case, can we talk about cure in some patients with these combinations with the very long tail on the curve, or is that still premature in hormone positive breast cancer?
Well, I think that, of course, in this situation, it's hard to say that we have cured these patients. I personally will continue therapy. I would not consider having a break, even if the patient is long-lasting in complete remission. But I think that probably with the activity of these agents, we are starting really to see patients that have complete response, as we now also have started before to see, in particular in the HER2 positive subset. So of course it will be very interesting to try to capture what are the characteristics also in terms of biomarkers or of also gene expression profile in those patients that still are deriving benefit after years from the diagnosis. And in this perspective, for instance, we are collecting in all metastatic breast cancer subtypes the data on the what we call the exceptional responders, meaning those who have, at least we have defined in our study, more than doublet of the median PFS observed in the study. And we are starting to collecting this data, and we are trying also to do some evaluation in terms of biomarkers to potentially understand why we have these patients that have derived this very, very important benefit from the treatment.
Now, the spectrum of disease is, Patrick, could change here. If this patient just had 1 or 2 solitary bone mets, didn't have the liver disease, and it's a de novo patient, and you potentially, because we haven't talked about operating on the primary breast mass here, and you irradiate the 1 or 2 bone mets, do you still think they should have an AI or a BEMA, or is there a role for endocrine therapy alone? And I'm really alluding, as you know, to a Dutch study here.
Yes, that's a super good question, of course. Even if you have a very endocrine sensitive patient who is oligometastatic, you might keep your CDK4/6 inhibitor for later. You refer to the SONIA trial, where this has been proven that there is no difference if the patient is postmenopausal in median PFS2. There is no difference in OS if you start the AI followed by the fulvestrant plus CDK4/6 in second line, as compared to the combination in first line and fulvestrant second line. So this patient might be oligometastatic. If she is premenopausal, Sonia has clearly shown during the last ESMO that we should not use this approach in premenopausal patients. But the fact that the patient has no change to an oligometastatic due to two bone-only lesions that you can irradiate, we would give it a go for 6 to 12 months with an initial treatment of an AI and see how this is going to react. If there is no new lesions that are coming on after 3 to 6 months, then we would even go for a cure, yes, but that's a different patient, I agree.
Yeah, it's a very different patient, but these are questions that we do have every now and then as
Yes.
we find these patients that have very limited de novo metastatic disease in bone. Valentina, visceral crisis is talked about, and obviously we have a trial, Right Choice, that's compared chemotherapy in visceral disease, not really true visceral crisis. But if the patient really have a heavy burden of liver disease and was symptomatic, losing weight, the liver function was impaired, the bilirubin was rising, where is there a role for chemotherapy here, and what's the sort of touch point?
Yeah, this is a really a situation, of course, very difficult because, we have, apart from the Right Choice, we have also other trials evaluating the role of CDK4/6 versus chemo in patients with this impending visceral crisis or very aggressive visceral disease. And in that patients, the data suggests a role for staying on CDK4/6 inhibitors plus endocrine therapy. And I have to say that from a clinical perspective, if you really have patients with compromisation of liver function, it's really hard to give chemo therapy in these patients. So probably I do believe that we really have to consider starting CDK4/6 plus hormonal therapy because it's easily manageable in terms of we can say day by day what happens. I have to say that it's a tough situation and you have really to monitor and close these patients. But because if you look at the time to response, if you look at also at the response rate, that are the data, that are the reason why still the guidelines suggest to go for chemo, you see that in the end we have no faster response with chemo. So if a tumor is endocrine sensitive, in my view, the highest chances to respond to endocrine therapy in
And
combination.
I think that's absolutely right. And I think a lot of clinicians around the world now understand and that, and the usage of chemo in these patients has gone right down. So let's say we treat the patient with a CDK inhibitor and an AI. They respond well. They're 6 or 12 months now in an excellent remission. Would you consider any ESR monitoring for this patient to look for the acquisition of ESR1 mutations? So the relevance of this, and we'll just provide the data and then have a discussion, is really all around SERENA-6, which was a study presented at ASCO in the summer and published in the New England Journal of Medicine, based on an initial trial, part of 1, but then this was the definitive trial. So patients who are in a remission for 6 months are screened for looking for just the ESR1 mutation with a digital droplet PCR test every 3 to 4 months. And if it's detected, they're screened to see if they've got metastatic disease on scans. And if they haven't, and it's just a molecular relapse of ctDNA with an ESR1 mutation, then the patients were randomized to either switching their endocrine therapy to an oral SERD, camizestrant, to target the ESR1 mutation with the continued CDK inhibitor, or remain on their aromatase inhibitor with a CDK inhibitor. And this was a placebo-controlled trial. 300 patients got to the randomization stage, and the primary endpoint was PFS by investigator assessment. And essentially, by making that switch based on a molecular relapse, you can intercept, as the investigators have said, the development of disease and put it back into a remission for a prolonged period of time, gaining an initial additional nearly 9 months of control, looking at the median there. As you can see, the hazard ratio of 0.44. So this was one of the highlights of ASCO, but raised a lot of questions as to whether this is an approach that we would take. So I just want to ask the faculty about that, as to whether or not you think this is ready for prime time, because do we detect an ESR1 mutation before the patient is clinically relapsing to get the best out of an oral SERD, or do we wait until they relapse and then give them the oral SERD? Patrick, what's your thoughts?
Well, Stephen, when I saw these data presented, I was actually present, and it was very impressive to see how early SERDs at the introduction in this place was camizestrant, if the patient have an emergence of the ESR1 mutation, can prolong the median PFS. But still, it took 9 months to see the difference with AI versus SERD. Indeed, there is a 7-month improvement in median PFS if you come to PFS 2. Still a lot of questions, a lot of issues. Who were these patients? Because as you have shown from the slide, they had to select more than 3,000 patients to find 350. But it's proof of principle that this is possible, but still too early to be used in the clinic.
I think so. And I think one of the questions that was raised is it cost effective? And I think unless the test was really as cheap as doing a tumor marker test that we do perhaps to monitor a CA15-3 every 3 months to monitor for early progression, it has to come down to that sort of level. And I think the technology is rapidly advancing to bring it there. Whether this is a sufficient route to get this drug approved based on this diagnostic in that setting, I think we wait and see, because it's not an approved option. But as you say, Patrick, it's a great proof of principle that if you find the mutation, just change the endocrine therapy. You can delay the time that patients need chemotherapy. Their quality of life was improved as well. So it was certainly thought-provoking. So we come back to this patient. We've given them their CDK inhibitor, and we've continued to monitor them. See if you vote again on your treatment options. Your voting will come back again to see what your first-line treatment would be, having had that discussion about choice of CDK inhibitor and choice of chemotherapy. So let's talk about the patient who then is found to have an ESR1 mutation. So we haven't done the SERENA-6 methodology. It's not an approved way to treat patients at the moment. But after 23 months, which is about the median, just under the median, Valentina from the frontline trials, she has developed further bone and new liver lesions. You do a liquid biopsy and you do find a CT, an ESR1 mutation. You don't find a PIK3CA mutation or anything else. So as Patrick alluded to, this evolution of ESR1 mutations during AI therapy is a dominant method of resistance. So we offer a number of choices here. So to the audience, please vote here. You've got a patient with progression after 2 years nearly of CDK inhibitor AI therapy. You've got a solitary ESR1 mutation. You've got a couple of oral SERDs, and Patrick showed the data for imlunestrant in EMBER-3, for elacestrant in ELEGANT. You've also got combinations of a SERD plus a CDK inhibitor, and you've got a SERD plus an mTOR inhibitor from the new Avira data. So choose any of those options, and this is assuming that they are available and licensed. So we're looking at in a world of the efficacious treatments being available, and we're not cost constrained. Oh, if we did live in that world, it would be wonderful, wouldn't it? But it's not quite the world we're in. So vote for that. And I'm going to just ask Valentina here what you think you would do. Would you, of those options, what are your thoughts about monotherapy versus combination in this patient who's relatively well and has just got a solitary ESR1 mutation?
Yes, I think this is a situation where I would take into consideration the oral SERD single agent, because in particular on the basis of an analysis from the Emerald trial showing that in those patients who were treated with CDK4/6 inhibitor in first line for more than 12 months, you can observe a median PFS that exceed the 8 months. So take into consideration the side effects and the possibility to further control the disease. I think that oral SERD and the data we have from the Emerald trial support the option of a single agent and oral SERD. Of course.
So Valentina, just
Yeah.
Just to interrupt there, one of the questions that came through is this 12 months of benefit from a CDK inhibitor a crucial criteria to give oral SERD monotherapy? Because obviously, in Emerald, they did that separate subgroup and showed the real benefit was in those who had already had at least a year of CDK inhibitor.
Yeah.
Should we be using that as an additional criteria to just the ESR1 mutation?
I have to say that I use this approach when selecting patients, and in particular for single agent oral SERD, because as Patrick described, unfortunately, we have a lot of patients that early relapse after starting therapy, and this is observed with a lot of the trials evaluating single agent oral SERD. So of course, the drop of the curves is observed even in those patients selecting for having prior prolonged treatment with the CDK4/6 inhibitors, but take into consideration the whole data. I think that this is something can be considered in particular if we are in the scenario where we can also consider other combination independently from the registrational from the approval. So in a patients with less duration, with less benefit from first line, probably I will consider the combination.
Okay, so one of the questions, Patrick, here is related to comparison of the oral SERDs, and you produced some nice data there comparing the spectrum of the oral SERDs, their differences. Now, certainly in the US, there's availability of either imlunestrant or elacestrant. How do you choose between the two? What do you think the differences in their profile are between those two agents? Do you have any thoughts on that?
Yes, I have been using both agents in the clinic, imlunestrant, because we participated at Emerald and we have had an early access program that now finished because imlunestrant is not going to be reimbursed in Belgium, not for the moment. These are drugs that for me are very well tolerable. I have given, elacestrant is not available in Belgium. Imlunestrant I have been giving through the different trials. We now have several patients on imlunestrant in the adjuvant setting and the AMBER-4 study.
Yeah.
This is, these both drugs are very well tolerable, and it would be difficult for me to choose between them because I don't know which of the one is going to be the best. But mild GI toxicity might be an issue, and it doesn't lead to drug interaction, to drug discontinuation. So I think both are possible choices.
So I think we've got a fair consensus here that we would probably be recommending in the second line therapy, particularly if a patient had demonstrated a good response to their CDK inhibitor. An oral SERD, imlunestrant, elacestrant are the two approved options, and that would be a reasonable therapy. And the data for the combinations we'll come back to. One of the questions is, do the oral SERDs work in patients without ESR1 mutations? Well, they are still often the case. And I think what you showed, Patrick, is in the patients that don't have ESR1 mutations, it matches equivalent to other therapies in
Correct.
terms of fulvestrant. So they are still drugs that will work. It's just that they work much better than the other drugs if there is an ESR1 mutation. That's my understanding.
Correct.
So with that in mind, have a think about your second line options for this patient and vote accordingly to see how your thoughts have changed. So we're just going to mix it up a little bit on this and have a slight variation on this patient and suggest that, Valentina, when you've been looking at this patient, you didn't find a mutation. So you draw a blank, and that's probably around about 50% of the time, isn't it? That you might have still evidence of ctDNA. It's important if you have a negative ctDNA test that it's not because there's no DNA. And if you do it in patients with just very limited bone disease, you may not find any DNA. But if you find DNA but no mutations, then you're essentially wild type. So the scenario is here, what would your options be? So again, if you'd like to vote, so we've got a scenario in second line with no mutations. So do you keep your CDK inhibitor and change your endocrine backbone? Do you go for a combination of a SERD with a BEMA as a CDK inhibitor if you haven't given that before? do you give a SERD with an mTOR inhibitor based on the data that Patrick showed you with Avira? Or are you convinced by the new data, assuming it's all available, with the getalasib, which is a multi-targeted PI3 mTOR inhibitor, IV with palbo and fulvestrant, the so-called triplet in the Victoria trial. And remember, those data were in those with PIK3CA wild type, so they had no obvious mutation. Or has the world become so confusing that you're not sure what to do? So if you'd like to vote on that, and I will ask my colleagues what their thoughts are on this scenario, because we've now got a Valentina no mutation. Do you think we still have to look at a combination to look at pathways that we haven't been able to measure? Is the new data really the resurrection of mTOR as a viable second line target in some form? Because we've had everolimus available before. What's your choice? Because this is a slightly confusing area for people.
Yes, I think that, of course, here the situation is much more complicated. We don't have a direction or go there. I think that probably there, also according to the data presented by Patrick, probably there will be some patient that can derive benefit from fulvestrant by single agent. But I think that with all the data that we have seen, probably we are all much more convinced about the possibility of trying a combination. So in my view, of course, everolimus is still an option, even in combination with fulvestrant, because here we don't have an ESR1 mutation. I have to say that I found very interesting the data from the AMBER-3 with the combination of, but the arm of the combination, because it seems that it works independently by the presence of mutation. But of course, here we have the patient that is progressed after, if we consider all the data of CDK at progression on CDK, the results, the positive results are mostly driven by those patients receiving palbo in first line. So, but I have to say that in this case, I think that imlunestrant abema can be an option.
Yeah, and I think that was a nice introduction to these data from EMBER-3 that were presented last year, that have been published, really looking in the combination here of patients with imlunestrant plus abema. Prior CDK, the vast majority of patients in the trial had had either palbo or ribo, so you're changing the CDK inhibitor and changing the endocrine therapy. But it appears to work, Patrick, regardless of ESR1 mutation status. So if you have no ESR1 mutation and no PIK3CA mutation, hazard ratios look very favorable for this combination of a SERD plus a different CDK inhibitor.
Yes.
If the CDK inhibitor had already been abemaciclib, it doesn't make that much sense. Would that be the case?
Yes, I think, coming back from ESMO in Berlin, there was a poster from Japan, and they have done a phase 2 study in 70 or so patients. They were all being treated in first line with an AI and with abema. And at progression, they changed the AI to fulvestrant, and then they reached in second line with continuing the abemaciclib, they reached a median PFS of 7.2 months. So this was only a small number of patients, but it clearly shows that continuing the CDK4/6 inhibitor, if these patients have been using this and can cope with the side effects, and we all know that the side effects from abema appear the first months, I think this is a good option to continue the combination. Just switch.
The data, yeah, it was tried with palbociclib, continuing palbociclib
Yes,
and changing
correct.
them in the
Correct.
PACE and Palmyra trials, but they were less convincing, weren't they?
Yes, that's correct. If you use palbo, this is different, but it seems to work with abema. I agree.
Yeah. Okay. All right. So this is certainly an option based on these data, which would support that in a setting of no obvious mutation. So I think that would be certainly a very reasonable option. The option of changing the CDK inhibitor and changing the endocrine therapy, we've just alluded to that here as being an option. Hitherto, I think Valentina, fulvestrant and everolimus was a very reasonable combination. But if these other drugs that target mTOR become an option, such as the Victoria option, or that could be something of interest in due course, because that was quite powerful data in that setting, in essentially with no obvious mutations. But combinations probably are sensible in that scenario. Right. So have a think about what you would do in that scenario based on that short discussion we've had there of those options. Would you change your mind from what you voted a few minutes ago? So we're going to just do the second case, and there are only 2 cases. We'll be a little bit quicker on this one and still keep your questions coming in, which we'll try and cover. So this is a slightly younger postmenopausal patient. She's called Julia. She's 56. And she presents with endocrine resistant disease on the basis of the fact that she'd had a prior primary breast cancer diagnosis and received her adjuvant endocrine therapy, but relapsed within 12 months of completing that. So remember, that's that definition of secondary endocrine resistance that Valentina was talking about, that is in the ESMO guidelines. So she has more extensive visceral disease than our previous patient. She has really quite a significant volume. Again, biopsy shows it's still ER positive. There's a low level of HER2 expression, 1+. So that doesn't switch as truly HER2, but it's the so-called new HER2 low. And the pathology confirms that this is her previous breast cancer that's returned. There's a family history, but there's no obvious BRCA mutation, and no other biomarker testing had been undertaken to date. Of note in her medical history, she has relatively poorly controlled type 2 diabetes, some evidence of some mental health issues, and that's a background to your treatment options. So remember, this is endocrine resistant disease, but potentially an endocrine sensitive option to whatever combination you think. So your options here are, would you go for fulvestrant and a CDK inhibitor? Remember, there's no CDK inhibitor usage to date. Would you use imlunestrant with abemaciclib in this patient? Or would you look for a PIK3CA mutation here? Because this is the group of patients where, as Patrick showed you, the INAVO 120 data show patients relapsing on or within 12 months of their adjuvant therapy. If they have a PIK3CA mutation, remember that could be up to 40% of patients, the triplet combination. But remember her comorbidities. Do you think she needs chemotherapy? She's symptomatic from her visceral disease. Or are you, again, a little unsure about how to proceed here? So we know that testing is important, and these are the ABC ESMO guidelines from the last 2 ABC consensus meetings about when to do the testing. And this is a rapidly changing field. It's certainly become much more mandated prior to second-line therapy, and liquid biopsies are as, if not more effective, particularly at finding ESR1 mutations, than tissue biopsies, and they give the sum of what's going on in the body rather than individual mutations. Patrick, you showed the INAVO data. In this patient, regardless of their comorbidities, do you think now to guide first-line treatment, biomarker testing is now mandated in a first-line setting in this patient?
Yes, it was actually Valentina who presented the INAVO, but it's fine. That's no problem. I think
I'll get both of your comments. Don't worry.
If this patient has uncontrolled diabetes, I would not go and test her. And I think we have the option with the CDK4/6 inhibitor, with a SERT or with fulvestrant. I think we have enough data from Monarch 2. We also have data from Amber 3. This is first line metastatic in patients who are endocrine resistant. So the diabetes would make a change for me, yes, Stephen.
Yeah, Valentina, you talked about the INAVO, and would you agree that you would test in this scenario? And if you did find a PIK3CA mutation, what would you be torn between numbers 1 and 2, and what would you decide you either way?
I think that, of course, in case of no contraindication to the use of inavolisib, I think that patient with endocrine resistant disease has to be tested for PIK3CA in first line to inform on the treatment selection. In this case, of course, the uncontrolled type 2 diabetes was an exclusion criteria from the INAVO, and I think that among the available drugs targeting the PIK3CA pathway probably is the one where we have to be more careful in the patient selection because of the risk of hyperglycemia and diabetes. I think that in this case, I would go for CDK4/6 inhibitors plus fulvestrant because we have subgroup analysis showing really impressive PFS in patients with the PIK3CA mutation. And probably I will consider the targeting of PIK3CA in second line because at this time we have the possibility of using CAPI, which probably is more flexible in terms of the possibility of using even in a situation where we have some problem in controlling glycemia, and of course having the time of course consideration. We have a lot of drugs now able to control diabetes, so probably using the time of first line setting to be really sure that this diabetes cannot be actively controlled and reserving for further in case of further progression.
And I think both in Monarch 2, which is fulvestrant plus abema, and in Arvo 120, which was the triplet, both studies have shown survival benefits as well as progression-free, very significant. So addressing one of these combinations does clearly have a survival benefit. And as you say, the PIK3CA may have a poorer prognosis, but it doesn't deny response to a CDK inhibitor. Patrick, chemotherapy, if this patient had much more symptomatic disease and you're thinking endocrine resistant because they're relapsing earlier, would you still not be tempted to chemotherapy? Do you think we've got better data still, even in this scenario, with combination endocrine therapy?
That's a good point. When do we have to give chemotherapy in these patients? There is no visceral crisis, I think, in this patient. So I would wait a little bit and give it a chance to combine an endocrine agent with a CDK4/6 inhibitor. I wouldn't give chemotherapy yet, but I think we have to follow the patient very closely. And if we see a response, we will see it quite quickly, I think.
Yeah, I think that's right. Okay, so if biomarker testing was undertaken and it wasn't a PIK3CA, but this time we found an ESR1 mutation, because remember the patient had had a prolonged period of adjuvant endocrine therapy, relapsed within 12 months, so they may have had an acquisition of an ESR1 mutation as their first line treatment. And there was a question from the audience earlier on to say, do we think the oral SERDs are really only second line, or would they work in the first line setting? So what do you think about this? And would you use monotherapy, or would you again use combination in this setting?
Well, there is a subgroup analysis that we have presented at ESMO Breast, and you can
Here it
see.
is. Yep.
Yes, thank you for showing these. That's from Amber 3, and these first-line patients were all exposed to abemaciclib and imlunestrant as compared to imlunestrant. You can see the data for single agent imlunestrant versus standard of care in the ESR1 mutated patients. But independent of the ESR1 mutation, the combination of imlunestrant with abemaciclib was doubling the median PFS in first line. So in this particular patient, I think this combination is working. If the patient has low tumor burden disease, if ESR1 is mutated also there, but these were very few patients, Stephen, that were included in Amber 3 in first line. But yes, theoretically, this can still work. But I would go for the combination.
Yeah, and I think the thing is, if you're ordering a liquid biopsy here, you're not just looking for an ESR1 specific mutation like in the testing for Serena-6. You're going to be getting a panel like the Garden assay, and you'll come back with a PIK3CA or an AKT or whatever. So by ordering a panel, you will be getting the chances. And we are finding, obviously, in these situations now, ESR1 mutations will be developing, so it's not specifically into the third line setting. One of the questions about the oral SERDs that's just come in is can they delay the use of chemotherapy in the second line setting? Valentina, what do you think? We saw in Serena-6 that that switch did delay the time to chemotherapy. Do you think ultimately it is all about maximizing your endocrine treatment until chemotherapy is required, and oral SERDs have a role in that as well.
Yes, I think that these are options that can restore endocrine sensitivity in those patients where the mechanism of endocrine resistance is driven by the emergence of the ESR1 mutation. So overall, this approach can prolong of course, the time on endocrine therapy, and this, of course, translate into the fact that we need to switch to chemo later, because we have an additional line of endocrine therapy, and so in particular we can have a situation where we have first line CDK plus endocrine therapy, then with ESR1 mutation we can offer oral SERD, and in patient with also PIK3CA mutation we can also consider the possibility of having endocrine therapy in combination with PIK3CA inhibitors, and as soon as we consider that the patient as potentially benefiting from an endocrine-based approach, and then of course in the end we have to rely on chemotherapy. So I think overall we can say yes.
So one of the other questions, and I'll take this, is really what's happening now if we have a lot of adjuvant CDK inhibitor usage. Is that going to change our options? Or whether the patient had received and completed their adjuvant therapy many years ago and had more endocrine sensitive disease. And that definition, which we started the whole meeting off of endocrine resistance and sensitive, still applies here, because perhaps this is then suddenly not an INAVO 120 scenario. But if you find the mutations, you may still want to test them. The concern has come that if patients are all having the CDK inhibitor in the adjuvant setting, does that change how we treat metastatic disease? And do we have any data? Well, there were some data that were presented at ASCO when we presented the data on Monarch E, showing a survival benefit in the adjuvant setting. There were data looking at the treatment that patients received on the first-line metastatic setting if they'd really received therapy in the context of this trial. It was a post-hoc analysis, wasn't protocol-driven, but the patients who were relapsing early within the first 3 years, so it's either 2 years on the adjuvant abema or a year after, with more likely to be CDK resistant, we would have thought, clinicians were much more likely to be giving those patients chemotherapy in that setting if they were on the right-hand side there, if they were orange and had been treated in the abemaciclib arm. And on the left-hand side, if they were in the endocrine therapy alone arm, they were more likely to get a CDK inhibitor. But the later recurrences, 3, 4, 5 years down the line, usage of treatment was relatively similar. The data are incomplete and it's just a snapshot, but it does give us a hint that those early recurrences of ER positive patients where they've already had their CDK inhibitor, patients are much more likely to reach for chemotherapy. Patrick, were you surprised by these data? Did this make clinical sense? Do you think it changes how we should approach these patients in the future?
No, I think, if you have such an endocrine resistant patient who is relapsing during or within 1 year of stopping the CDK4/6 inhibitor in the adjuvant setting, this is an aggressive population, and it's not unlikely that these patients were more likely to have chemotherapy, whereas you haven't given the CDK4/6 inhibitor, it's very normal that you see more CDK4/6 inhibition. We will have to see what's going to happen, but we now have an OS benefit, which is absolutely reassuring in Monarch E, for me at least.
Sure. So we're coming towards the end of our discussions here, and I think what's clear is that we have options of combinations for this endocrine resistance scenario, and that we may make a choice depending on quality of life, toxicity. The INAVO data is clearly important, but we have to be careful if there are comorbidities, because these drugs do target the insulin pathway. And so choices of other drugs which can still work in PI3 kinase, but particular mutations are important. Now, have a vote on what your options would be for treating Julia in that particular setting with endocrine resistant disease and a PIK3C mutation with concurrent diabetes, and see what your thoughts are. So we're coming towards the end of our treatment. I may just move through this, that if we have combined mutation testing. So she initially went on to fulvestrant and a CDK inhibitor was stable, and then in addition to the PIK3CA mutation, developed an ESR1 mutation. So you now have dual mutations, and you've already treated the patient with fulvestrant based therapy. What are your options now? Would you give an oral SERD on its own for that ESR1 mutation, having treated them, or do you think they now need a combination such as fulvestrant and capivasertib, and you just try and manage the diabetes? Fulvestrant's already been given here, which may or may not be an impediment to exposure to the drug in our country. If the patient's already had fulvestrant, we can't then give the fulvestrant capivasertib combination. Or would you use an mTOR inhibitor? I don't know what our faculty thinks about this situation. Valentina, just very quickly in that scenario, second line now with an ESR1 on the background. You haven't treated necessarily the PIK3CA to date because we elected to give fulvestrant and a CDK inhibitor. Do we now come in with all our targeted agents, and if so, what?
Yes, I think that in this situation we have a patient presenting with endocrine resistant disease, so probably at progression I will prefer to have a combination therapy, and I think that we can stay on capi fulvestrant or taking also into consideration the ESR1 mutation, probably the results of EMBER-3 are, I have to say, somehow reassuring on the performance of the combination in or with or without mutation. So, but and I think that all combination options can be applied here.
Yeah, and we're still short of data of some of the new oral SERDs combined with the PI3 kinase inhibitors. Some of those trials are still ongoing. So I'm going to bring this to a conclusion in terms of some of the main messages that we've had today. I think we're saying that we would still certainly go on and target the ESR1 mutation in this patient with a PIK3CA mutation. Obviously, her comorbidities still make us think about what the treatment options are, but with, as Valentina said, properly managed diabetes does allow you still to give these agents. You just have to be very careful. So let us know what your thoughts are on the treatment combinations that you would use for that patient who has then, in the second line setting, now developed an ESR1 mutation plus a PIK3CA. We used to think that these were mutually exclusive, but there is now clearly an overlap where these mutations can coexist together. So in terms of seeking consensus, the new treatment algorithm is something a lot of us have been thinking about. And we just put up for your interest, really, a one-page summary of everything that we've seen recently, including the new disclosure at ESMO, around the discussion that we've just had. So we've looked at two scenarios here in terms of patients, either the de novo metastatic disease patient or potentially endocrine sensitive, a very long treatment-free interval, versus the second option at the bottom there, treatment-free interval of less than 12 months of adjuvant endocrine therapy. And clearly CDK inhibitors in the first-line setting are there. Whether we switch based on a SERENA-6 scenario, I think is still questionable. But at progression into the second line, this is where it's become increasingly complex. And the genomics will tell us that we may have no mutations. We may have an ESR1. We might have a PIK3 pathway. We potentially could have a BRCA. We might get combinations. And obviously what's clearly changed is that while monotherapy with an oral SERD is very effective in ESR1 mutations as the sole mutation, particularly if they've had a prolonged period of time in response to the CDK inhibitor, combinations are increasingly coming in as options, either for ESR1 mutation or for wild type scenarios. And based on data, not availability of the drug, these are potentially the options that you may have. And you can download this slide from the practice aid. So in terms of all of your questions, I think thank you very much for bringing those through. I think we've covered quite a lot of those issues. We haven't got time to cover necessarily all of them, but I hope that that has been a helpful discussion for everybody about really the complexities that we now face in the first line and the second line setting, and the principles really of still making sure we define endocrine resistance versus endocrine sensitivity, and then look with our patient at their choices and then the combinations or monotherapy options that suit them the best. So please make sure that you complete your evaluations for this credit. You can download the slides and the practice aids, and please stay tuned for any further activities related to this event. And please also submit your feedback on this activity. So I'd like to thank my colleagues, Patrick Neven, Valentina Guarneri, and all of you for joining this activity. Thank you for your engagement, and I hope you found the discussions and the evaluation of the data that's just come out recently helpful in your clinical practice on a day-to-day basis. Thank you.
Thank you.